destiny.
Hello, a good day to you all. It's good to have you here again on our third day of the implementation webinar series. So today we have a new facilitator, and I'll start with introductions, and then we'll move on to our today's session. Today we have Professor Nathaniel Cirilli. Prof. Cirilli is an associate professor, a distinguished scholar and practitioner in health systems and implementation science at Muhimbili University of Health and Allied Sciences in Tanzania. He trained at Umeå University in Sweden, and he has over 15 years of experience in designing, implementing, and evaluating complex health interventions in low and middle income settings. His work integrates implementation science, health policy analysis, and system strengthening to bridge the gap between evidence, policy, and practice, particularly in primary care, emergency care, community health systems, and workforce development. Professor Cirilli has led and contributed to multi-country, multi-partner research and implementation programs supported by agencies including WHO, UNICEF, CEDA, GIZ, and Abbott Fund. And he has applied frameworks such as CIFAR, REAIM, and participatory action research. He's a committed educator and a mentor, and he has led curriculum reforms, advanced competency-based training, and supervised over 90 postgraduate students. He serves in editorial and advisory roles for several peer-reviewed journals and national policy initiatives. His work is characterized by rigorous scholarship, stakeholder co-creation, and a commitment to equitable, resilient, and people-centered health systems. He has published over 100 peer-reviewed articles. Professor Cirilli would like to welcome you to our implementation science series, which started on Monday 26th, and today is the third day. We are really grateful to have you here, and today's session is about implementation science methodologies. We look forward to a very interactive session, a very informative session, and I believe all members who have joined here today are looking forward to learning. We also shared the examples that were to be reviewed prior to the session so that people are acquainted to the examples. I think that's going to be more relevant or relatable to today's session. So, Professor, you're very welcome. Professor, can you hear us?
Yes, I can hear you very well. Do you hear me?
We can now hear you. Thank you.
Thank you. Yeah, I have realized that there was some setting I had to do in my computer.
Okay.
And thank you. But I heard you very clear when you were giving the introduction. So shortly I will share my screen so that learners can see. I have already been introduced. And I think also they have also seen my image, the picture, who am I. I have not changed. I'm still the same since the last time I shared that photo. I'm still the same. And yeah, let me share the screen so that we can move from there. Oh, it's telling me the file type is not supported. I'm wondering. Okay. Here I am. Do you see my screen?
It's currently loading. I hope we'll see it soon.
Yeah. Have you seen it?
No, it's not visible yet.
Wow. Okay. Yeah.
Not yet.
Mm.
Oh,
Cancel
we
and
can,
wish.
yes, we can now see it. Maybe just if you
Okay.
put it in slideshow,
Okay.
we can perfectly see it now. Thank you.
Hello, everyone. Depending on the location you are in the world, good morning, good afternoon, and good evening. Speak with you this evening, partly sharing my little experience on the implementation science, designs, and specifically I'll use really examples from Tanzania, from projects that have been involved for quite some time. And my assumption is you have been able to go through the 2 pages. It's too short, so I expect that even 10 minutes are fine to at least to get the ABC of what we are going to cover. So I refer village emergency care model, snake bite and venoming, and continued professional development are the 3 projects that I'll use as examples for teaching. I must confess that my training does not involve at any point degree of education. So I am not a teacher by profession. So allow me to present, but at the same time, I allow you to interact at any point in time to ask questions, clarifications, so that I can express myself better for you to understand what is being covered. I am going to share with you the designs, but I'll touch a little bit on the constructs and the outcomes that we measure in implementation science. So this session covers introduction to implementation science through really projects. We are learning from designs through village emergency care, snake bite and venoming, and we continue develop professional development examples and how we move from theory to practice. But again, we'll touch a little bit why understanding this design is important and why design choice matters. Then we'll link research to health systems strengthening, and we will focus on understanding scale and sustainability, and we'll appreciate real world complexity. But the whole session is framed around Tanzanian evidence. So why implementation science? I suppose my colleagues, Professor Kalolo and Majani and other, have shared with you the first important part on why implementation science is. But before I move into design, I wish to highlight some key things that will help in my sessions. Most of interventions, especially in low resource settings, fail after pilots. And many ask themselves why they fail. One, sometimes the evidence from the pilot does not reach the practice. We collect evidence, We publish papers in scientific language, in peer-reviewed journals. And those who are to use the evidence to implement, it doesn't reach them. And sometimes we even complain as scientists that they are not using our research findings. There is so nice research here, but they are not using it. And we complain. But the major reason is we don't put the evidence in a simpler language, and we don't engage them to understand that it matters and to see that it is working and how it works. But again, because of poor engagement, sometimes health workers resist the programs that are designed by other people coming. Especially in low and middle income countries, this is a major problem because of shortage of funding. We'll have donors coming from other places because they have funds. They will tell you how to design the intervention without knowing the local context. And eventually, they face resistance from the local people. When the interventions they think now are ready for adoption, the interventions cannot be adopted. I have so many examples of that kind of projects where I was involved. And at some point, we reached disagreements with colleagues from outside Tanzania that this is not the way the program can work. Our context is different. Sometimes they will push that, no, this is the way it is because they have money, you will stay aside. They will move, eventually they will hit a bouncing block because it cannot move, because it didn't take the important considerations. But again, systems behave very differently from the controlled environment. Normally, when we pilot, we put everything ideal, and we don't really think that when you are putting an intervention, it's normally operating in a real world setting. So we think the intervention will move in the very same way as how we found when we have controlled environment in the pilot, where you push also a lot of resources, everything moves smooth. But when we come to implementation, we realize that the systems behave very different. We do not take care of the behaviors of the community. At some point, we just bring the interventions, moving from big towns, big cities. You take an intervention in the rural areas, you think like you're in the city, it fails. Leadership and governance influence uptake. How you engage the leaders, the local leaders, the influential people at the community. It's not necessarily every time you consider only leaders with the titles. Some people are just leaders. They don't have any title, but you reach a village, you find there is someone who is famous. That make sure you engage that person. When you get that person, you realize many people will follow. I don't mean you should ignore the hierarchical leaders, but also identify other people who can foster the intervention. Sometimes the resources, logistics, and culture affect the success of interventions. So you realize in pilots, everything is controlled, but after pilot, all these other things has to run in place. So implementation science studies how to introduce these changes. I have summarized what other colleagues perhaps would have said in many slides, because my focus is not to tell you what is implementation science, but rather to move to designs. So in summary, again, to summarize what I have said, implementation science now is the study of methods to promote the uptake of evidence. So it focuses on adoption in routine care. We have seen there that adoption is a problem. But again, it is not about control setting. So we come to look at the feasibility and acceptability from the community. We look at fidelity of intervention, how it will be implemented, what things to consider, what are the barriers, what are the facilitators, or sometimes we call them enablers. How we ensure that the intervention will move. Some good interventions die immediately after pilot because lacking sustainability plan. So we study sustainability over time while we're implementing, we integrate little by little, we ensure that our intervention is adopted. But again, we look at the context and the behavior. Remember, I've said in the pilot, most of the things are controlled, and the behaviors of the community, it does not matter. Really, at that point, you control them. It's not only look at does it work, but you also look at how it works. So in other words, it looks at both outcome and processes. Most of our research focus on outcomes. They don't look at the processes. But when you come to implementation science, the processes sometimes matter than the outcomes, because we understand that it is the means just that justify the result. But if you look, there is popular means that popular myth that the end justify the means. But here, the means dictate the results. That's how implementation science look at things. But again, implementation science is a bridge between research and health systems that is fostering the uptake of evidence and how the evidence can be integrated into real practice. How should we differentiate implementation science from the traditional designs we know? Traditional designs, most of the time, they consider things as controlled environment. So they look at efficacy, while implementation science tests real well use. Everything should come together. In a traditional setting, we focus on selected participants. But in implementation science, we wanted to know the behavior. So you really patients or really clients or really community, we assess where it is really taking place. And traditional design use research stuff, while in implementation science, you go back to the routine. Who are the people there? Integrated them from the very beginning. Traditional design, a short term. Implementation science focus on long-term integration. And that is why most of the time it is expensive to carry implementation science, because you need the follow-ups or you need interrupted evaluations. Any question before I move or any interaction? Just unmute, or I can help to control from the other end. Am I heard?
Sure.
Naima?
Yes, yes. I think if anyone has a question, they'll just raise their hands and we'll allow their mic. I guess there's no questions as of now.
Okay, so silence means I should proceed. Thank you. So I gave you three exemplar projects. One is the village emergency care model, where in one of the districts from northern Tanzania, that is in Kinga district in Tanga, we identified one village which was far from the facilities. The nearest facility was 9 kilometers, which is different from the ideal villages in Tanzania, as most of the villages are estimated or approximated to be within 5 kilometers from the healthcare facilities. So this one was 9 kilometers away. So with the support of Abbott Fund Tanzania, Emergency Medicine Association, and the institution where I come from, university, we identified that village called the Bantu, where we introduced village emergency healthcare level by building a dispensary which contained an emergency care unit. We trained staff at this facility that we developed on emergency care, basic first aids, and we also raised community on emergency issues, first aid, and the need for taking any person with emergency or acute condition to the facilities just immediately after provision of the first aid. We adopted before and after evaluation design. That is, we carry the baseline situation before developing the facility. We assess the knowledge, the access, the awareness, and the referral system from the nearby facility to the regional hospital, emergency conditions, and the affordability and the acceptability of services. We used a mixed method approach to conduct it, which this was a sequential, where we started with quantitative data collection. After analyzing, we carried the qualitative to explain what we saw in quantitative. Then we designed the village emergency care model. We conducted a midterm evaluation after 1 year, where we improved the implementation by additional training, and also by revising the health insurance system, because the facility was not accepting insurance. So we ensured that the health facility was accepting the insurance systems. And later on, at the same time, we studied barriers in the other facilitators at both the individual, community, referral, and facility level. So after the second year, we carried out the end-term evaluation, and we realized in the very first year after mid-term, we designed also plan for adoption to other places. That is for scale up. But after the end of year 2, we conducted end-line evaluation, and we realized that it was working. So the answer, does it work, was answered. Then we conducted a sustainability plan to see how we plan. In the 4th year, we evaluated the sustainability to realize, does it work? We realized it has worked, so we handed it back to the district. And then we moved to other villages, as you see. As we moved to other villages in other regions in Dodoma, where we were implementing it Bantu. In Dodoma, they were acting as sites. So we just carried baseline and we did nothing. But after midterm evaluation, we introduced the interventions in these 2 villages. And we conducted midterm evaluation where we were conducting end-term evaluation in Bantu. So we conducted midterm in Dodoma and there. And in the 4th year, we conducted end-line evaluation in Humwa, Dodoma, and Kinyala, Mbeya, while we introduced Kagera and Kigoma as control, did baselines. And in the 5th year, now we are moving to implementing Kagera and Kigoma, while we are introducing another village in Songwe as control. And later on, we introduce intervention there. So this is the village model. We wanted to ensure there is access to healthcare services at the village, emergency care at the village level, which is not happening in Tanzania as of now. As of now, the village, the emergency care services mostly established at the regional and tertiary facilities, with a few district hospitals having emergency care. Although we have established that at the district, the emergency services do work effectively. So we wanted to establish if it can also roll out to the villages. That is the emergency care. In the same vein, we introduced the community integrated surveillance system and response model. And we went in the very same district, that is in Kinga. Based on another study, we realized that snake bite and animal and insect-related bites were a large problem. And one of the major problems was lack of adequate data, people not going to the facilities, and instead going to traditional healers. And so the facility had the underreporting of the burden. So we introduced this CSRM model to be able to ensure that those people who are bitten by snake at the community level immediately get assistance from either community health workers or traditional healers, and they are linked to the facility and referral. We used the so-called MAMA, emergency transport linkage, which is a local transport system designed to ensure that pregnant women reach the facilities, especially during the time of delivery, using private vendors in the district will pay to ensure that everyone, despite of lack of ambulance, can access the facility. So we used mixed methods, qualitative and quantitative, to collect the baseline information. And we did stratified sampling, where out of 85 villages of Mkinga district, we reached 74 villages, having reached a total of 1,573 households out of 34,000 households in the district. And our aim was to improve data accuracy and access to care, and using the co-creation model to develop this model with the stakeholders. So in this one, we are looking whether this system will work to be able to improve access to care for those who are bitten by snake. But we also want to see how the healthcare workers will receive this system, or will adopt this system, and other stakeholders for it to be accepted. The third one is continuing professional development in Tanzania, mainland and Zanzibar, where we understand that continuous professional development globally has been proven to be an intervention that ensure that healthcare providers or any profession do maintain its competence and skills for improving services. So in Tanzania mainland, there was a framework since 2016. Its adoption was little. There was fragmentation on how it has been done. There was issues in the governance from the national level to the lower level. But again, those who were in urban area were much more favored to access of CPD activities. Accreditation tracking was not that much really done. But again, for Zanzibar, there was no CPD framework at all. So it was fragmented. There was no institutionalization to the professional councils. But again, there was no clear map on compliance on this. So in this one, we were revising for the mainland Tanzania, while we are developing a continuous professional development framework in Zanzibar for ensuring that the CPD framework is adopted in Zanzibar as well, or you may wish to say institutionalization of CPD activities. So the second project for the CIS RM model is funded by Liverpool School of Tropical Medicine for Wellcome Trust and the African Snakebite Alliance. And this third one is funded by UNICEF Tanzania. So those are the three projects that I will use as examples. So my main subject for today is the families of implementation designs, but I'm required much to discuss the hybrid effectiveness study designs. But I thought it's important to have this slide, and I will not be happy if I end with the hybrid effectiveness designs instead of without touching the stepped wedge design, which is more ethical in public health. So we have hybrid, we have step wedge, but we also have pragmatic trials, we have mixed method designs, we have adaptive or PDSA designs, we have process evaluations, we have realist evaluation, and we have participatory or co-creation approaches. All these are applicable and acceptable in implementation science. So we will move now to look at one design after the other, after I have also explained a bit about the project in Tanzania. So if any question before I move, especially in clarity of the three projects, because now we will refer them without giving details. Emma.
Thank you very much, Professor. There was a raised hand by Yakub Jimo. Yakub, if you can unmute your mic and address your question. If not, there are two questions in the chat box. The first one, someone asked how strict.
Good afternoon. Hello.
Okay. Yes.
Sorry, I have a question to ask. Like, I don't know, like the implementation. I'm new to all this, so so it's somehow kind of confusing to me. So I don't know the implementation science. Is it like maybe implementing particular aspect of a research that have been proven or something? Like maybe if I carry out someone else, let's say I carry out research now on, let's say, malaria, maybe a drug that to actually cure malaria, and I discovered a particular drug. Is it that the implementation science is bringing that particular drug I've actually discovered into to like bring that drug I actually discovered, like taking it to the people that actually need it, like maybe the hospitals, and distributing it? Is that the actual meaning or the example I can give for implementation science? Hello?
Thank you very much, Yakubu. Partly yes, partly no.
Okay.
The definition of implementation science depends on what you are aiming at carrying out that research.
Okay.
If the malaria drug is not in place and you are aiming to discover it, research. But if it is already in place,
Okay.
and we don't know if it works, then we can start to have the first aspect of implementation science by asking the question, does it work? Okay, that's the first aspect. We are looking at the effectiveness of that drug. Forget about the efficacy. That if we look at the efficacy in the controlled setting, that is a controlled one. Implementation science want you now to look at this drug in the really community that suffer from malaria. Give them, does it work amidst their behaviors of kind of food they eat, the way they sleep with mosquito treated nets or not, the way they expose themselves to other conditions, their nutrition. So you ask yourself, does it work to this group? That is the first term of implementation science, to answer, does it work? And then if you move another level, does it work and how it work? Then that is also implementation science. So while discovery research or evaluation research at some point ask only the question, what are the results of it? If I give the patients this medicine, I come and look after them in 3 weeks, what will be the result? That will be an evaluation or a trial. But if I want to know how it has worked despite their behaviors, which I study all of them together, that becomes implementation science. I'm not sure if I have really responded, but as we move with the designs, you will be able to see the differences. I'll try my best.
I appreciate it.
Welcome. Yes, Naima, another question?
Thank you, Professor. I think we can proceed for now.
Okay. Okay, so yeah. One may ask what PDSA is. It is planning, do, study, act. That is the adaptive. You plan, you do, you study, you act, you move again. That's how it goes. That it becomes flexible now and then. So I will focus on the hybrid designs. The question is, why are they called the hybrid designs? One, they look at both results and process. That is, they combine effectiveness and implementation. Is it effective? How is it being implemented? Or what is the implementation fidelity? But again, they study outcomes and uptake of it together, outcome and adoption together. So is normally when you hear hybrid, is a combination of things. It's just an English word. That hybrid is a combination of things. It's not one. It has more than one thing in it. So this one, the conventional research, most of the time we look at the effectiveness, or we look at factors influencing implementation. That's public health view. But now in implementation science, we don't look at only the process. We look at the process and the preliminary result or the final result. But again, is conducted in real systems. I have said this. You observe both the implementers and the beneficiaries at the same time, staff and community behavior. You allow learning during the implementation. That is, we observe and we add changes little by little. As I gave an example of the VEC model, we started in Bantu, we scaled it up to Dodoma, Huma, and Kinyala. Then we scaled it up to Kagera and Kigoma. Now we are scaling up to Songwe. But again, it's designed for scaling from the start. So since the beginning, you think that this will be rolled out. So it's not one thing that is started today and end today. That's why it's expensive. If I look at the example of the VEC model, every year we spend around 200,000 US dollar. So if we're in the 5th year, that means we are going close to 1 million US dollar. So that is a lot of money in Tanzania. That's more than 2 billion. So you need to really invest when you want to move to implementation science, especially for an intervention that you want to adopt. But also you can do scale, try to very early, but at least you need 2 years, not just 1 year, so as to be able to have observed the changes and to promote adoption. So, but again, you balance regularity and practicality. It's not about just methodologically, but it's also, is it practically feasible? As your methodology is very good, but then is it adoptable? So it really reflects the real health system complexity. You know, health system act in pluralism. So everything is complex in health system. It's not just, you cannot say the hospital can function because it doesn't have medicine and supplies. You may have medicine and supplies, you don't have the right workers. You have the right workers, then you realize that they have skills, but there is no financing. There is no salaries. You get salaries, you realize that the information system is not working. So you cannot capture data. You bring the information system, you realize that everything in shambles, leadership is not in place. So systems are put in plural because many things has to come together. And implementation science has to look at all those in all angles. So now I go to hybrid type 1. Type 1 focus on effectiveness. Does it work? And the secondary outcome for type 1 is implementation. Does it work? If you look at VEC, in Bantu, our main first question was, does it work as our primary outcome? When that was answered, we asked ourselves, how does it work? So normally it is used when an intervention is new in the context. So you learn how the system reacts, you observe early barriers and facilitators, you measure outcomes in real settings, and normally it requires mixed methods. So this is normally in the early phase of intervention life. When you introduce an intervention, you start with hybrid type 1. And some of the intervention can move from hybrid type 1 to type 3 as we move. So in fact, you see, it was new in Tanzania. We adopted a before and after evaluation. We used mixed method. We started barriers and facilitators. We analyzed the community and facility perspectives. We assessed the staff capacity at the facilities. We looked at the referral patterns, and we were learning all this while we were testing this model, if it works. That is hybrid type 1. You look at primary outcome is effectiveness. Does it work? And your secondary is how does it work? Type 2, the focus is on outcome and adoption. Okay, does it work? How can it be adopted? You start thinking of acceptability and scalability. Does it work? Yes, it has worked. Does it produce the intended result? Yes, it produces the intended result. How can it be adopted to other places? That is hybrid type 2. So you study acceptability and feasibility, you study system behaviors, you study how stakeholders interact. It requires strong qualitative work. It's used when intervention is partially known. It allows refinement during study. It is normally at mid-maturity stage of intervention. And if you look at snake bite, it's developing as hybrid 2, we're focusing on data accuracy. That tells you that the data capture system was already in place, but was not complete. We are looking at hotspot mapping just to improve accuracy. If you look at access, the community health workers and traditional healers were already in place, but we wanted to bring them in question to create another model where they can collaborate and cooperate. The referral system was there, but was not starting at the community level. So we wanted to strengthen the referral pathways. We want to understand the community behavior. Why are they going to the traditional healers instead of going to the facilities while the facilities are there? We wanted to study technology adoption using the mobile app to ensure that the traditional healers and the community health workers use the mobile app to send information to the facilities. So we are looking at outcomes and implementation at the same time. So when you adopt type 2, outcomes and implementation are inseparable. Type 3, primary focus is on implementation. We know it works. How it works is the main things. Outcomes are secondary. So we understand that the intervention has already been put somewhere else. So we focus on governance and systems. We focus on policy and regulation. You focus on monitoring and compliance. And normally type 3 is at institutional or national level. And if it's an intervention, normally is at the latest stage of maturity. It has proved somewhere else to work and how it works. So you want it to look at the context of implementation in your setting. In this case, CPD is a good example. It's known to work globally. So we want the professional councils to adopt the framework. We want to focus on accreditation systems, the digital tracking, because the other places they have worked. It's about adopting in our settings. We want to focus on equity of access to CPD activities. One who is in a rural area, one who is in urban areas, one who is less trained, one is more trained. They should have equitable access to CPD activities. We focus on compliance for license renewal, which is fair, and we focus on institutional ownership, that they must own the framework. It's not our property, but rather it is the government property. So all the 3 types are conducted in real settings. They require a mixed method. This is a core point. You should not speak of hybrid design and you only have quantitative or qualitative research methods. You study adoption context. They are normally designed for scale. If you look at all of them, they only stress the importance of engaging stakeholders from the beginning. They observe barriers and facilitators. Despite that outcome is either primary or secondary, they both combine processes and outcome data, and they inform policy and practice. How are they different? In summary, type 1, ask if it works here. Does it work? Type 2, ask if it works and how can it be adopted. Type 3, ask how to institutionalize. But again, they differ at the maturity stage. Type 1 is at the early, type 2 is at mid, type 3 is at late. differ by primary focus. Type 1 focus on outcome. Type 2 focus on adoption. Type 3 focus on implementation. But again, they differ by level of implementation, as I have said. One is at the early stage, the other is at mid, and the other is at the maturity. And the good examples we have seen is VEC, SB, SPD, where VEC is type 1, only at band. SB is type 2, and CPD is type 3. So normally, the design, this hybrid design, how we choose it is looked at the maturity stage. If we is the early adoption, the early introduction is step 1. If it's at the adoption stage, that is step 2. If it's at institutionalization, is type 3. Any question to the hybrid before I move to step wedge? Yes, this means proceed.
We have a question. Sorry,
Okay.
Professor.
Okay.
We have a question from Bikila. Please unmute your mic.
Yes. Thank you so much. I think I am here. Yes.
Yes, we can
Hello?
hear you.
Thank you. Yeah. Thank you so much. Thank you so much for this wonderful explanation. My question is: assume we are going to start a new implementation study in a certain area using a diversified approach. So can we, in a single study, start from hybrid type 1, then go to hybrid type 2, then type 3 in a single study? For example, if that study or if that area of study started from the new one, like that, for example,
I cannot hear you clearly.
in Tanzania.
It seems I can't hear you clearly. There was an interruption in the network. Would you like to start?
Okay.
Yes,
okay.
Thank you.
Thank you.
Yes.
Can you hear? Can you hear now?
Yes. Now I can hear you.
Yes. Thank you so much. The question is, assume if we want to introduce a new approach like that you did in your real setup in Tanzania. So can in a single study of diversified approaches, can you use hybrid type 1, type 2, and type 3, so that you can check from starting from the effectiveness to adoption to the implementation? Can we do in a single
yes.
way?
In a single intervention,
Okay.
yes, but it will take you quite sometimes because you need to test if it works. We'll need to move on how can it be adopted, and then you'll have to move on institutionalizing if you want to be taken as a national agenda. And actually, that is what we are doing for the VEC. We are moving now we're in adoption stage. So now it's on design is type 2, and soon we will institutionalize by developing a national blueprint and integrate it into the policy. So it will become type 3.
Thank you. Thank you.
Have I responded?
Thank you so much. Yes.
Thank you. Thank you.
Yes, Professor, we may proceed.
Thank you. So now moving to stepped wedge design. This is not going to be the most ethical for our intervention. Most of randomized control interventions, they have one group that benefits the intervention, another become control, and it doesn't benefit. So in a stepwise design, with the first approaches, we start by introducing the intervention in one place, and then over time, those sites that were controls now get the intervention as well. It is more ethical because it's take into consideration equity. It allows comparison across time. It is suitable for scale up because the one that was control, now you move the intervention there and you add another control, then you move the intervention there. If you still have resources, you add there, then. So you have limited resources because of that with little resources. For instance, in VEC, as we saw, we started in one setting because we had little resources. The other control, so just baseline. Then when we had the resources, we added to the other sites. Another year, we added to another site. So you don't really see that you are spending a lot of resources, but eventually we realized that cumulatively there was adequate amount of resources over the years. But again, it brings a strong causal inferences because you can compare now. Sometimes you can do different from these sites by comparing one site to the other, especially when you're making endline evaluation. But again, it is natural for rollout for Ministry of Health interventions most of the time because it is starting in one place, then you roll out to another place. So a good example, as I have said, is the VEC. We started in Bantu, we moved it to Ihumwa, then we moved it to Kinyala, we moved to Kagera and Kigoma for scale up, and the sites served as time comparisons. So we learned across the phases and we scaled that when we move it to the same. So yeah, we have this one. I have summarized it in this table. How it is different from step wedge. Hybrid, the three designs, their primary focus is early learning about how the interventions works in the system. But for step wedge is scaling strategy for introducing intervention across many sites. So the main question for the hybrid is how is the intervention adopted and how does it function in a real setting? While for step wedge is how can the intervention really be rolled out gradually while allowing comparisons. In terms of number of sites for hybrid, fewer sites, pilot adopters, while for step wedge, many sites are introduced over time. Intervention for pilot, while for scale up is mature stage when intervention is ready for scale up, that is step wedge. When you have done in pilot is when you move to the next. The key interest in hybrid is adoption, feasibility, acceptability, and system behavior, while in step wedge is timing, sequences, and phased implementation. And in terms of type of learning, in a hybrid, you learn while testing, and you refine the model while you move, while in step wedge, you learn while you expand coverage. You don't learn in the very same place, staying there saying refine this, you refine, you put it in another place, you realize some issues, you refine them, you add it in another place. So it is scaling up while you are learning. It's like a football team. There is no time to say, now I'm preparing my team. You have to prepare a team while you are getting results. That's the step wedge. You move to another stage, you get a result, you improve, you move to another stage, not to stay in the same setting. So design logic, it combines effectiveness and implementation research. This in step wedge, it uses time as the comparison factor across sites. And the typical use case for this what I've seen, introducing a new model, VEC in Bantu, snakebite in Mkinga, while expanding proven model for VEC, it like in Ihumwa, Kinyala, Kagera, and Kigoma. So you are expanding, you are not just testing. The data emphasis is mixed methods, strong qualitative and process data, that is implementation science. In step weight, you have routine data, trend analysis, and comparison over time. And yeah, unfortunately, my screen does not allow me to read the last one, but it's outcome. You have it in your, you will have the slides as well. But mostly the outcomes in terms of the implementation in science, you want the effectiveness, but in terms of the step which you want to see the outcomes focus on rollout. So they are not without limitations. Hybrid type 1, the limitation is always hard to differentiate effect from context. So measuring only does it work as a focus is not always true. But again, you only have small sites, so its practicality of generalizing what you get in one place for massive rollout may not necessarily be possible. But again, learning may bias your outcomes because you want to learn to see what is happening and forget about the outcomes. Again, you overcome this limitation with the strong qualitative data. So you must have strong qualitative data. You need to have a clear evaluation framework, like the REAM framework. Document the barriers clearly and repeat in other settings. Use it as a learning phase. That's how you overcome the limitation for type 1. In type 2, one of the limitations is complex data collection. So you need a multi-skills, multidisciplinary team. You need heavy qualitative data workload, which sometimes make it hard to analyze. But again, you overcome it using a strong framework like the REAM or CIFAR framework, which I assume that you covered with my colleagues. But again, you need to develop a clear logic model. You need to maintain good documentation and as well having a strong monitoring system. For type 3, outcomes is not the main focus. Outcomes appear weak. It focuses on systems, not patients. It's hard to publish clinically. Yes, of course, you need to be very good in process papers to publish hybrid type 3 institutionalization. These are called the process papers. That's why they're not very many. You need to overcome with the process indicators, use governance metrics, things like it has, you have qualitative indicators most of the time, because if it is a framework, it is either in use or not in use. You show compliance improvements, you show equity improvements, and you link to policy outcomes as the way to overcome these shortcomings. For step weights, it is time trends may affect the results. It is logistically complex because you need to move from one setting to another. You need resources, you need strong, you need this multidisciplinary teams. So sometimes staff may get sick because of doing the same thing over time, and it takes much time. So you overcome by ensuring you have routine data, you have good scheduling, you have strong coordinators, and you complement with strong IT teams. So, as a reflection to what you have covered, think of a project, identify its maturity stage. Remember, I've said either early or mid or late. Explain why it is, choose an appropriate design, explain why I have chosen that design, identify the stakeholders involved, identify possible barriers, identify the data you need, and share insights with your peers at your place. If they understand you, you are ready to go. If you have not understood you, then you need to start afresh. Any questions before I move to another slide? This you will do at your own time. It's not now. Any question or contribution before I move to the remaining few slides?
Thank you very much, Professor. We have a question from Ojo Victor. Ojo, if you can unmute your mic.
Yeah, thank you very much.
You're welcome.
Can you hear me?
Yes, I hear you very well.
Yes, thank you very much, Prof, for the presentation. It was a very great one. Going along. I have a question on hepatitis B elimination intervention in a very very low resource funding project. And the question goes thus: how can hybrid and stepped wage design help us to learn fast, adapt early, and justify scale up despite funding constraints? Do you get my question, Prof?
Very well. You wanted to eliminate hepatitis B using a hybrid and step wage.
Yes, design.
Yeah. Maybe we a bit. How do you want to eliminate hepatitis B? What do you want to do?
Okay. It's a project that is an hepatitis B intervention project, elimination project that that will have resource funding constraints. So how can these two designs help us to learn fast, adapt early, and also deliver credible hepatitis B elimination results that justify scale up despite these funding constraints?
Yes, I have got you clear. My question is, what specific actions do you want to do so that you eliminate hepatitis B?
Yes, one of the actions is first, actually the proposal that was granted. First thing is on hepatitis B testing, which is screening. We have hepatitis B vaccination, and also the linkage to care for those that are positive. It involves the way of them, and the advanced stage of this is to link them to other cares. So there's a funding constraint, and also there's a limited time for this project.
Okay, so I find that falling under hybrid type 2 because it is proven that vaccination can eliminate hepatitis B. Is that correct?
Yes.
So if we already have a proven intervention that hepatitis B can be eliminated by vaccination, the big question we have now is how do we adopt it and implement it in a scalable way to ensure that we eliminate hepatitis B. That means you the process elimination. So mostly this is hybrid type 2, and you cannot use step wage because using step wage, it means you want to introduce it in one setting, test if it works or not work, roll out to another setting, see if there are things to improve for it to work or not, and then roll out. But for this one, we already know that the vaccination works to eliminate hepatitis B. Yes, for that matter, our intervention is not about does it work. Our question is how do we adopt it to ensure outcomes. So we stay at the type 2, hybrid type 2, and then we choose one setting which we understand that the prevalence is high. We can do even a quasi-experimental with another place where the prevalence or incidence of hepatitis B is not is comparable. And then after that, when we have seen it works, we adopt it, we link it to the government to take up for rolling to other places. So I think it fits to be hybrid type 2.
Yes, thank you, Prof. I actually thought it was the same direction too.
Thank you.
Thank you. Thank you very much.
That gives me pleasure that my subject is being understood. Thank you very much.
Thank you, Prof. Thank you.
Thank you very much. We also have a question from Mengstu. I hope I pronounced that well. Mengstu Melkamu, please unmute your mic.
Thank you so much, moderator. Thank you so much, Professor. It is well organized and well explained. I really appreciate for your interactive, presentation and explanation. Really, it is very high level. Thank you so much for that. My question is, are you hearing me?
I hear you very well. Thank you for appreciation.
Thank you so much, Professor. My question is, as hybrid design and other study designs you already mentioned, but hybrid designs are, there are, approaches. When, as you mentioned, there are three. There are also their own, intention or intended to focus, as you mentioned, effectiveness or combined effectiveness and implementation process, as well as, the process, the third one. But you explained, hybrid designs with stopwatch. Design. For example, there may be a study based on, the different reasons, as we explained, focus on, stopwatch design, but there is also a possibility to use, the parallel cluster randomized trial related issues, as well as, factorial design. But how we compare, hybrid designs with stopwatch, as well as, other study designs, because, hybrid designs are, approaches rather than study designs. This is my question. Over to you, Professor.
Thank you. Thank you very much. Yeah, it's a very pertinent question that the hybrid at some point are considered as approaches, but at the same time, they can be by themselves standard designs. Why am I comparing them with the stopwatch? Is because hybrid can be an entry point to the stopwatch, and also stopwatch can move from RCT. In some places, one may decide to move with stopwatch and stand with it as a design alone, forgetting about the three hybrid designs. For instance, the Vecchi model, initially the way we had planned it, we are planning it for sustainability and scalability. We had no question about looking at it as hybrid designs. But immediately before we started implementing, we realized that no way, there is no way we can move by saying this is only a stopwatch. We need to introduce a hybrid, which is a component of implementation science. The stopwatch sometimes can work not only as implementation science, it can be a scale up of any strategy. So it is sometimes fall under implementation science, and it can also fall as an adoption strategy. So it is important to compare them and differentiate them, especially with early adopters of implementation science, to understand that you can move from the hybrid and then move and traverse all along the way to stopwatch as another important approach or designs to link to what you are doing in implementing intervention. So I find it is a practical question based on my own experience, how we struggled, whether are we doing hybrid type 1, are we doing hybrid type 2, are we doing hybrid type 3, are we doing stopwatch? But we realize that you can choose the hybrid type 1 as the entry point, but if you are thinking of scaling up in the very same line, you have to think of the wedge design. I'm not sure if I responded or cleared the confusion.
Thank you so much, Professor. Thank you so much for your explanation. Thank you so much. Thank you.
Welcome. Yes, any questions so far, or we proceed?
We have a last question from Boniface Deus. Please unmute your mic. I guess we may proceed. He'll perhaps ask later.
Now, with that reflection, the final take-home message for the designs is that the design follows the life cycle of intervention. Pilot stages use hybrid type 1. Learning stages use hybrid type 2. Scale stages uses step wedge, and institutionalization use the practicality of implementing our interventions, and designs responding to systems reality. And these 3 projects that we have used really demonstrate the designs. All these 4 designs have been reflected. So another important element that I thought is good, I spent the last few minutes to introduce them to you, is the implementation science construct outcomes and measurements. Forget anything that you learned from the first day, but remember, when you're using these constructs, which later become concepts, you are speaking an implementation science language. 1, adoption. Who takes up the intervention and who does not? If we are assessing who take the intervention and who doesn't take the intervention, we are actually using an implementation science construct. 2, acceptability. How stakeholders perceive the intervention. They accept it or they do not because of the cultural reasons. That is a construct in implementation science. Feasibility. Is it feasible to deliver this intervention given our context and resources? Can it be delivered by these resources we have? Fidelity. Is it being delivered as we intended to be delivered, as per the procedures or guidelines? How are we penetrating or integrating into the existing systems or routine services? That is penetration. Sustainability. Will it live beyond the project funding? Appropriateness. Is it fit for purpose within our context? And how many, or what percentage of the target population are we reaching, are benefiting from the intervention? So adoption, acceptability, feasibility, fidelity, penetration, appropriateness, and reach are among the key constructs in implementation science that you will find most of the time when you are coming across implementation science. Looking at our examples, what do we measure as outcomes? In EVEC, we are measuring adoption. Is it adoptable? We want to see the primary healthcare staff using triage and stabilization. Is it acceptable? We want to see the community trust in the dispensing services so that they can go there instead of going to traditional healers. Fidelity, do they use the protocols we have trained them to do as they are supposed to be used? Integration or penetration, how are we integrating the routine emergency care to the workflow of the facility and even the district systems? For the snakebite adoption, the community health workers and healers want to use them to use the reporting app. Is the community willing to report snakebite and go to the facility instead of going to traditional healers? Feasibility. Is the use of a mama transport referral system work in our context? And we want to see coverage across the 22 wards. to see if our population benefits. For the CPD framework adoption, we want to see the councils adopting the CPD framework and using it. We want to assess the feasibility of the digital tracking of credits as the outcome, and linking to the essential, that is an integration, that is penetration. And in terms of sustainability, we want to see it owned by the institutions. So what do we actually measure? For the village emergency care, we want to measure time from arrival to stabilization. It's the one who has reached the facility until when he has received complete care and is stable. But we want to look at the number of emergency care services provided, number of emergency cases that have been managed at primary health care. We want to shorten the referral time, and we want to look at the staff competence and confidence, which can be measured qualitatively through observation and questioning. For the SBE, we want to measure the number of cases reported by the mobile app. We want it to measure the time from bite to facility care. We want to understand the concentration where snake bites occur and community seeking behavior pattern. Community healthcare seeking behavior pattern that is changing from traditional healers facility. For the CPD, we want to see the percentage of professionals involved in CPD. We want to see number of accredited CPD activities, compliance for license renewal, and equity of access to CPD opportunities. Ladies and gentlemen, those are my few slides. I have partly touched, as I said, briefly, the construct, the outcomes, and how we measure them. If there is any questions, I'll be more than happy to discuss.
Thank you very much, Professor, for this wonderful session. I believe we've gotten a lot of information, a lot of knowledge for us to contemplate and see how we can implement implementation science in our daily work. There are a couple of questions that were shared in the chat box, so I'm going to project them, and perhaps we can take a look at them in the remaining 8 minutes that we have.
So I should stop sharing, right?
I guess you already stopped sharing. I'm already sharing my screen.
Okay.
Yes. So the first question was asking, how strict should we be in sampling and methodology when conducting implementation research?
Come again?
How strict should we be in sampling and methodology when conducting implementation research?
Okay. Okay. Should I take it as they come, or?
I guess so. I hope you can all see my screen. We have a couple of questions. I'm not sure if we can cover all of them.
Then I think I can go with of them because I see them.
Yes, sure.
Okay. Yeah. Okay. Yeah. So one, how strict should we be in sampling and methodology when conceptualizing IR? Of course, implementation science research is a methodological thing and as well as a ethical thing. If we are not methodologically rigor, they will say your evidence is weak, so they'll not adopt it, especially for integration. So it's very important to ensure you are both methodologically sound and you are ethically sound. So the answer is, as implementation science required methodological rigidity, and one of the rigidity component is the sampling part. Implementation science primarily focus on findings from basic foundation research published by researchers in other fields, or they mainly implement interventions they have developed themselves. Not really. You can assess intervention that are conducted by other people to see implementation fidelity. That's why I brought the constructs. You look at implementation fidelity, you look at the feasibility of adopting them in your setting, you look at institutionalizing. For instance, Tanzania is not the country that designed the continuing professional development framework, but now we are looking at how to institutionalize. Another question is which frameworks are appropriate for there is no single answer to this. The design also depends on the type of intervention that you want to put. It's not only about one framework fits for all, but common framework used at the framework like RE-AIM, which is reach, adopt, implementing, effectiveness, and maintain, or CIFAR framework. Those are the common ones. Major framework being used in implementation science, but there are so many other frameworks depending on the discipline that you are assessing. For instance, if it is clinical intervention, you'll also need to take care of the clinical protocols that are in place. If it is a community-based, it will have also to look at the community level setting protocols. So there is no single framework that this is fits for all. It depends. But again, how does implementation science guide medical correction when projects are off track? Yes, because you are monitoring. Right? There is a component of monitoring what is happening. So when you at the mid, you realize things are going astray, you have the room to redesign. You redesign and you implement for it. And I think that's why that's where step wedge comes in place. That you redesign, and instead of doing it in the same place, you take it to another site. Is it possible to develop an implementation science study that combines elements from each study type? The answer is yes and no, because type 1 is about does it work, type 2 is about how to adopt it, type 3 is how to institutionalize. So you can have starting from 1 to 3, but you cannot have all of them in one setting. What is the best approach for carrying out IR that focuses on implementation of reforms? For instance, you conduct an IR for the evaluation of health insurance scheme that is already in operation. Yes, here you will need to conduct things like acceptability. Remember, at the community level, acceptability of the insurance, you need to look at and in this case, we'll be analyzing either the inner setting or outer setting, looking at the system level, how the system level is trying to integrate it to the lower levels. Because most of the time, insurance is not that it doesn't work because of how it's being integrated and adopted, and due to low community level acceptability. And you also need to look at, for instance, who have the insurance and why they have, and those who do not have, who adopt and who do not. So it is some of those kind of questions, and of course many other. Because health reforms is about moving every now and then, you can also look at the implementation fidelity. Thank you very much. I think I have quickly summarized the responses to all the questions that I see on the screen.
Thank you very much, Professor. I think all questions have been addressed. I hope today's session was well understood. I hope we are all going to now digest what we learned and get prepared for the upcoming session. Professor, we really thank you for being with us today and sharing this knowledge with this great team of professionals who are willing to learn. We are really grateful for that. Members, congratulations for making it this far from the beginning to where we are right now. I mean, your commitment and resilience is a great picture of the commitment you seek in learning more about implementation science. So I'd like to urge you to stay put and p.m. East African time. Please let's remember to join in time. Let's get acquainted with Microsoft Teams earlier to avoid any inconveniences in joining the meeting when the time arrives. Otherwise, the meeting recording and presentation will be shared in the shared drive. And I now think you're all already working on your assignments. I'm going to share the link for that assignment again, just in case someone did not see it, so that we can all now use the knowledge we have gained in the past 3 days to respond to those questions. So thank you very much, Professor.
You're welcome.
I
Thank
wish
you very much. Yeah. Bye-bye.
Thank you very much. Wish you all the beginning or start of your days. See you tomorrow.
Make-A-Wish is the place for destiny.